So our next presentation is Carmen Lopez from Manitoba, Canada, and she's going to present Dignity, How a Simple Question Can Help to See a Patient as a Person and Enhance Their Care. So Carmen, will you come? Okay.
Thank you for that box, for whoever.
We just moved it from that side over to this side, since
Perfect.
it made more sense over there.
So
Just the green.
just the,
Yeah. Or if you want to go back, you can use the red.
just gonna put this here for now.
Sure.
so we need it.
That's fine.
I have to read something from there.
Okay.
Hi, good afternoon. Oh, Dipti, where are you? Oh my God. Like, I considered just hanging out with the candies after, because really, I don't know what I have to say after what you said. I mean, it was so moving, and I was so honored to be able to listen to you. It's absolutely fabulous. And you're coming back with me to Manitoba. So, Dignity Project. It's, first I'd like to say that it's a real pleasure to be here amongst colleagues and patients and organizers, and I'd like to sincerely thank KNCV and the organizers and the funders, because I really feel deeply that when we gather and we share our experiences, that we're stronger and we go back with renewed sense of purpose. I also would like to thank the Dutch people, because as I realized last night when I left my union bag with my laptop in it at an outdoor cafe at 10 o'clock at night, and I was on the bus back to my area of the city when I realized, got off the bus and started running. I'm 60, I'm overweight. I had heels on, which usually I don't wear, and I ran for 4 blocks, and there it was. She was already trying to locate who I was and what hotel I might be in. I have no idea how she did that, but it was fabulous. So there we go. I'll be taking these on and off only because I'm having to read some notes. So, as I was introduced, I'm Carmen Lopez. I've been a nurse for 30 years, first in clinical practice in a hospital, then in public health, for many years in northern Manitoba, which I will show you where that is right now, and later went into the research, mostly with tuberculosis and HIV. So, in essence, similar populations I've been serving for most of my life. Within this project, I was affiliated with the University of Manitoba and the Regional Health Authority in our city. There are no conflicts of interest that I know of, that I can remember.
Or that you're willing to.
Or that I'm willing to share. So I just want to read something to you because it's so interesting. Now, yes, granted, my focus has been dignity in this project, but I've done basic science and I've done public health and all sorts of research. And so I'm seeing dignity everywhere right now. And I'd just like to read to you in the first few pages of this lovely guide. The conference theme, Declaring Our Rights, Social and Political Solutions, highlights that eliminating tuberculosis and achieving the health-related Sustainable Development Goals requires a coordinated public health response driven by the human rights of each individual. I heard those terms yesterday in an Indigenous forum talking about Indigenous rights, about the struggle for Indigenous people to have dignity as part of their care and their relationships with our communities, with our governments. And so that word is everywhere, and it can mean many things to many people. This is where I live. And actually, I will mention Indigenous people because they carry the burden of illness as they do around the world. And in the larger cities in Canada, it's also the new Canadians. Well, I was a new Canadian. My parents also immigrated to Canada from Spain and Germany. And so at one point, I was a new Canadian. And I remember some things that happened. So just to narrow down, because Canada, you could fit Europe and half of Eastern Europe, I think, into Canada. So I'll just narrow it down for you. We are in the center, Manitoba, and my province is Manitoba, and this study took place in Winnipeg. There's a difference, and the reason I mention it is because in Winnipeg, it's the largest city in our province. It has about 650,000 people. The folks who develop tuberculosis in the city are predominantly new Canadians, so 60% of the cases to 70% are new Canadians, and the rest are Indigenous or self-identified First Nations people. Outside that city, it's completely reversed. The burden of illness is mostly Indigenous, First Nations, Métis, and sometimes some Inuit, although the Inuit live further north. Our province has about 1 million people, more or less. Like I said, Winnipeg's 650 to 700,000, and there are close to 100,000 self-identified Indigenous people in our province. So you can see that they carry the largest burden, and yet they're 1/6 of the population of our province. So, let me check my notes. I tend to do this. The Dignity Project originated from an idea that we adopted from somebody else. Dr. Harvey Chochinov is a psychiatrist who works with cancer patients. And he observed and had read about issues of dignity and personhood in the care of people with tuberculosis. And he wrote, he said, and I will quote, "To a healthcare professional, one's illness is a routine incident. For the patient, it may be a crisis in his life. To feel sick is one thing, but to feel that who we are is being threatened or undermined, that we are no longer the person we once were, can cause despair, affecting body, mind, and soul." Most patients who get cancer are not our vulnerable population. It's not overrepresented. It's everybody across the board. Imagine now, on top of that, with the burden of tuberculosis, HIV, to be in a vulnerable state, socially, emotionally, culturally, on top of that. So that's one of the reasons why this intrigued us so much in the tuberculosis unit. Take something that was looked at in cancer care and apply it to the people we serve in tuberculosis. So, what is dignity? What does dignity mean? Any examples? Any words that come to your mind? Respect. Anything else? An individual. Do you know when your dignity has been offended, stepped on? How do you feel? When there's been a lack of respect for you? Have you ever been indignant because of the way you've been treated or talked to? We've all probably been patients at one time, or even just in our own communities in different ways. Dr. Chochinov called it a quick way to put personhood on the radar, who we are as people. State of being worthy. These are some of the ways that we can consider someone's dignity. And tuberculosis and the treatment of tuberculosis and the care of people with tuberculosis is all about collaboration. Deep Teeth talked about the stigma, about being blamed if you spread the disease, of being blamed if you don't take your medication. Well, you know, if I was a single mother with 5 kids and had very little resources, The last thing that really would interest me is whether I take that pill, which means in Canada going to the nursing station sometimes in 30 below zero, or in the city, you know, going to the clinic. So, you know, it's about perspective, and if you look at the individual and from the individual's perspective, which is hard, I think, for all of us to do all of the time. These glasses are going to kill me. Being heard. So, what did we do? We applied a similar question to the one that was developed by Chachanov. But what we did is we had two sites, two clinics. One is where they treat active disease, and the other is where they treat patients with latent tuberculosis. So very different groups, very different systems. One is full of public health nurses, the other is a community clinic. We had approximately 60 patients in a period of 3 months. And there were also very different dynamics with the staff. So as the project manager, I met with the staff, and together with the staff and the patients that they served, we proposed the question, and how would they like it written, and how would they like it to sound. And so we did all of that. That was the preliminary work. That's not the part that's really interesting. You can read that. Oh. So in the analysis, after 3 months, we had about 58 responses, and we noticed that there were some themes that emerged, and they were very strong themes that we could put the different responses into. So we categorized them by sense of self, emotional, mental, spiritual, internal stressors, and the external or internal environment. Those are big words, but we'll get to them. So the theme of sense of self. The people told us about their deepest sense of who they are. They told us about who they are as people, what they value. I was a nurse, a frontline nurse for many years, and I had responsibilities in how many patients I needed to see, and I had medications to give, and I had my own family to feed after work. And so we are on a schedule. We have demands, all of us do, and we consider ourselves good human beings. That's why we are in nursing. We want to help and support people. However, I think that sometimes there needs to be a reminder to each one of us. And what we were hoping to do is to normalize and formalize a question within the program of TB Health, so that we would not forget to ask a very simple question that can actually tell you so much about a person and can actually help you to provide them with care as well as know them. When we lose people to care in TB, the question is why? Who were they other than a case? What is it about them that could help us to understand how to provide them with better care and more efficiently? So the sense of self is about how do you describe yourself when you're asked. How do you describe yourselves? Just think about that. Do you describe yourself as, I mean, I've been at many gatherings where the first thing that people say to me is, what do you do? And that puts a category around who you are. What do you do? Where do you live? Depends on the neighborhood you live. That tells me a lot about you, doesn't it? What community are you from? What clan are you from? How do you contribute to the world? I like to ask people what they read. That interests me more than what they do for a living, although that's important too. So people want to be understood as a person, not an illness. And that's really important, and actually it's so beneficial. When I talk to people in this study and in previous studies, it was amazing the stories I heard, especially new Canadians who we assume because they're in housekeeping, that we categorize people in terms of the level of how we're going to teach them about TB, what language we're going to use. But how do we know who they were in their community, in the country they came from? And Indigenous populations, they shut right down when they're confronted with our healthcare system, properly so, because of the historical indignation that they have endured. People told us they wanted to be in control. They wanted to know about their results. They wanted to be taught and explained, and that's about dignity. I remember a woman in the hospital in another study I did, an Indigenous woman, and they told me, when you go into that room, be careful, she's really angry. And I said, oh, I love angry people. So I walked into her room and I sat down on her bedside, and I just said, you know, I'm old, my bones, can I sit? So I sat on her bed with her. And at one point she looked at me and she said, just once, I would like someone to come in here and tell me what's wrong with me. She said, I'm an Indian, but I'm not stupid. And I went back to my office and I wept, because I thought, we do that all the time. It's done to us as well. And we know how it feels, but we do that all the time as a healthcare system. It happened to be a large teaching hospital. People are in a hurry. They bring students through. They forget the person that's lying there and what their experience is in terms of, just turn that camera around to see what they see. People told us about their doubts, their fears. Who are they? They want to be understood, and they want to know and understand what's wrong with them. They told me I was infected with HIV. I know people with HIV. I had surgery, but I didn't know what the surgery was for. How can someone not know what the surgery's for? How is that possible? Was the surgery for HIV or TB? Now, what's wrong with that answer? What does that tell us about things? Sorry. The other category was emotional, mental, spiritual. So internal stressors. Are any of you afraid when you're told you have something wrong? Add a stigma to that and see how you feel. There's stigmas that we apply societally to so many things, and I've often wondered, why is that? Deep Tea talked about, you know, if you have cancer or if you have malaria, you're okay, but if you have tuberculosis. So we see it as an ordinary thing because that's the realm that we all work in. But for an individual, it's not. And the occasional active case in a non-Indigenous, non-New Canadian, in an event in our province was a very prominent person in our community developed TB. Nobody talked about it. That person didn't talk about it. Nobody talked about it. Private. And that person is one of the most prominent and respected people in the TB community. No, they didn't want anybody to know. So think about that. So the fears and anxieties that come across, and people hide their fears and anxieties. You don't know how I'm shaking up here. Like, you know, we think about that. And Deep Tea talked about stigma, which was, you know, it's all-encompassing in tuberculosis. How will other people will find out. People already have other stressors in their lives. And on top of that, now they have the stress of TB. In one example, I had a young woman I was working with, and she had tuberculosis, and now she was returning to her northern remote community, and she had a job in a store, the only store in this community. And somebody had picked up the phone and called her workplace to tell them she wouldn't be in because she had TB. They said it across the whole store. And when I talked with her, she was sobbing. She didn't want to go back to her community, and she knew she would lose her job. And it's that whole feeling of, you know, we have to hide this. And all of these things need to be heard. So the Dignity Project was so fascinating because it allowed the nurses to hear patients things. 2 minutes. Oh, okay, hold on. 2 minutes. Where am I? Racism is a It's not a perception, it's a reality for many people. And you can read what I've got up there, but a gentleman said to me, well, the young woman I explained to you that what she said, and this gentleman said that he was treated as if he was an alcoholic and with liver disease, and he had lupus, but he happened to be indigenous, and this happens all the time in our country, and it's not necessarily done knowingly. It's a systemic thing that occurs, and for new Canadians, very similar experiences. So that's really important. Where are we? Oh, I have to go ahead first. So we're talking about also the last theme was external and internal environment. And that's people want to be seen as responsible in their communities. They have duties just like the rest of us do. We want to be seen as people. Don't we all want to be seen as responsible people? We're not just this disease. And we want to be seen as who we are in the world. And for many people, it takes time to build trust to tell you those kinds of things. They're more than just an illness. What we lastly did is we asked the same people if they would evaluate what we had done, the question we had asked, did they think that it affected their care? And it was interesting because the patients thought that it acknowledged their humanity, and they thought it made them feel more welcome, and they were seen as individuals and human beings. They thought it was important to ask that question. So we were hoping to formalize it within the Regional Health Authority as just a reminder of asking. With the nursing staff, and I completely understand it, just going to go to the nursing staff. They thought it was a good question. And there was a variety of age groups in the nurses. Some had been nurses for 20, 30 years, and some were new nurses, 3 or 4 years in practice. And there was some resistance to the whole project because it's insulting to consider that I, as a nurse who take care of people with TB, have to actually now formalize a dignity question. I do that with all my patients, don't we all? Don't we treat people with respect and dignity? And that's how some of the staff felt. And then after the project was completed, some still felt that way, but many others thought, you know, it did help, and I want to use that. There was one nurse who on her own just started using the question within her own patients, without being part of the project, because she said it was fascinating. She asked one of her patients, without even telling us, what do you think about this question? And he said, you really actually want to know how I think? What I think about? How I feel? And she's a wonderful nurse, and really attentive and caring, and treats people with dignity. And she was surprised at how a simple question could still elicit a relationship. And many of the Indigenous people said that they really liked the question because it takes a lot of time to develop trust and build trust, to tell you who I am, as I think it does for most of us. You're not going to tell people everything. So asking the question is important, but perhaps repeating it along the way is even important. And so we had some thoughts about this whole project. You know, was it worthwhile? Do we propose the question several times in the care of people with TB? In other words, go back and repeat the question after you've seen the patient 3 or 4 times. The patient charter for TB care is really clear. It requires that patients are treated with dignity, so it should be throughout the process. How can we know whether this is done if we don't formalize it sometimes within a program? We have a lot of declarations that we all make, mission statements, value statements, but right embedded into the work that we do, the forms that we fill out. It's okay to have things like that. It shouldn't create a stressor for us as nurses. It just allows us to focus again on what is important to that patient. 0 minutes. I just want to acknowledge, I have to acknowledge Vince Ten Av. He's the media guy. He helped me put the project into the right format. Took an hour. He was great. I'd like to also acknowledge colleagues and collaborators, most of all the participants. As Dipti did to me now, these patients taught me so much. So I have one more thing I need to read. And it's just, I read it this morning and it was so powerful. It's by an author called Ursula Le Guin, and she's an American writer who's deceased, but she said, "Every act of communication is an act of tremendous courage in which we give ourselves over to two parallel possibilities. The possibility of planting in another mind a seed sprouted in ours and watching it blossom into a breathtaking flower of mutual understanding." That's a little flowery. And the possibility of it being wholly misunderstood, reduced to a withering weed. Candor and clarity go a long way in fertilizing the soil. But in the end, there's always a degree of unpredictability in the climate of communication. Even the warmest intention can be met with frost. Yet something impels us to hold these possibilities in both hands and go on surrendering to the beauty and terror of conversation. I love that, the beauty and terror of conversation. That ancient and abiding human gift, and the most magical thing, the most sacred thing, is that whichever the outcome, we end up having transformed one another in this vulnerable making process of speaking and listening. Thank you so much.
Thank you very much, Carmen. I think you really planted a seed in our hearts that it's very important to not only emphasize with our patients, but see them as persons and not only as patients. And it's always good to be remembered by that. Are there people who want to ask a question? Yes, Linus.
Carmen, thank you for your inspirational, inspiring presentation and about the project. I'm wondering, Manitoba is in the middle of Canada, but does the project and all the things around it also spread over Canada? Because there's more to do, I think.
There's much more to do. No, this was a unique project, a year grant funding. We wanted to do a phase 2 where the patient would actually be able to evaluate their whole care path, which starts in hospital or in community hospital and then back into community. Nobody was interested in funding that, which is to me, like a whole. It's our opportunity to hear patients like Dipti.
Thank you.
You're welcome.
For having success in reducing TB, we have to have eye for our patients, but not only for our patients, also for their family and also for the health workers themselves. Our next speaker will teach us about the training and the fit testing activities which they use in his hospital in Lusaka, as well as the activities for healthcare workers, as well as the activities for the patients and their family. I would like to introduce Jojo Moyo.
Thank you so much. Good evening. I'm Jojo Moyo. I'm from Zambia. I'm a TB nurse, and I work for the University Teaching Hospital. My presentation is on the infection control initiatives at the University Teaching Hospital. This is my conflict of interest disclosure and my introduction. Zambia is a Southern African country with a population of approximately 16.59 million. HIV prevalence is at 11.6 and HIV TB co-infection at 70%. Thank you so much. Okay. Tuberculosis is the leading cause of morbidity and mortality in Zambia, and the leading cause of illness in people living with HIV. Our first prevalence survey was done in 2013 to 2014, and it was found that out of every 100,000, there were 638 cases of bacteriologically confirmed TB. And in the Copper Belt, which is the mining province, it went as high as 1,211. Zambia is one of the 30 countries with high TB and TB-HIV burden in the world. MDR-TB, only about 10% of estimated cases are detected, and the cure rate is at 51%. We actually started the short treatment regime last year in 2017 in Zambia. Okay, this is a picture. On the left, there's the University Teaching Hospital. That's the main entrance. It's the biggest referral hospital in the country with over 3,000 employees, over 1,000 nurses. And on the right, that's our new TB and MDR TB treatment center. As you can see, there's the OPD side with the waiting area outside, and this building is actually as admission wards for only MDR TB patients. So I divided my presentation on infection control into patient-centered approaches and healthcare worker-centered approaches. On the patient-centered approaches, we have the MDR TB outreach, the patient-relative sensitization and screening, and the quarterly facility assessments. On the healthcare worker-centered approaches, we have the annual healthcare worker screening, and then the trainings, TB infection control trainings, and the fit testing trainings which we carry out. So on the outreach we began in 2015. It was an initiative by the nurses in the TB clinic, because at that time the cure rate was 41% for the hospital, and we're having a lot of loss to follow up. So the nurses approached the management, we wrote a letter, and some partners came in. They started providing transport. Initially it was done monthly, now it's done twice monthly. They also provided the lunch allowances for the team and some food supplements for the patients. The team is made up of a clinician, a nurse, an environmental health nurse, and a driver, of course. So I chose this picture for a reason, and the next one as well. This home belonged to one of the first patients we actually found when we started outreach. This patient had been lost to follow-up for over 12 months. We managed to find him and put him back on treatment. And the patient actually comes from a very poor area. But I chose this picture because of, in our culture, we believe when someone is sick and they are your neighbor, you have to visit them. If you don't, they may never talk to you again. So you can imagine all those neighbors, and you can imagine how the contact tracing was like. So I actually managed to collect about 21 samples. They all came back MTB negative, apart from one, which was positive, but it was reef sensitive as well. So it was, the source patient must have been someone else. This is the second program. Patient-relative sensitization and screening. This was also an initiative by the nurses in the TB clinic. It's almost like part of intensified case finding, because what happens is that at the moment it's done quarterly, but we hope to start doing it monthly eventually. The partners came in again, and the drama group is actually made up of community volunteers, treatment supporters, TB treatment supporters. We invite different groups from different clinics because they don't have much of incentives. So we've taken it upon ourselves to make it as an incentive for them. They come, they act out these plays, sensitizing the crowd about TB. At this time, we mainly focus on the medical wards. We talk to the in charge. We tell her we have this activity from 10 to 12. Please make sure all the bedsiders, visitors attend it, and then should direct them. And as the drama group is performing, we actually set up tents. As the drama group is performing, they'll direct these people to these tents. And at the tents, there you have a nurse. We have two nurses, two TB nurses doing the TB screening. There'll also be a nutritionist who will be doing BMI and also advising people on nutrition, and also an HIV counselor. Normally, the average numbers we test, they actually go up to 50. We have 50 people, between 40 and 50. It varies between that number. And once in a while, you find maybe 2 or 3 HIV positive patients, but normally it's only 1 or 2. And then, of course, we collect the samples for Gene Expert and we have the contacts for these patients, and we contact them with the results, whether they're positive or negative. And then the other activity we do is the facility assessment, and we have a tool. And of course, on the left there, you see that those are the things someone has to fill in if they're the one carrying out the activity, their name, address, phone number, and so forth, and the dates. And the objectives, of course, are to identify departments, wards with poor TB control practices. And then when you identify this, you discuss with the department head or the ward manager. And then, of course, the very important part is investigating the reasons, formulating strategies, and implementing and monitoring those strategies. And in the next quarter, again, you do another evaluation. Then you can revise your plan. The idea is just to keep improving on the TB infection control practices in the facility. This is an example of the tour. I just picked out a few points. There's the managerial, administrative, and of course, there's the environmental and the PPE. I put one point in under each heading, like for example, managerial here. The question is the national infection control policy is available on site. So we have a policy in the hospital that every department and every ward should have this policy. So that's the first question on the two. And if it's not there, of course, you indicate no. The comment, normally you'd indicate two to be made available. And of course, you have to indicate a date so that it can be evaluated. And of course, there's the administrative controls. The example I put there, patients are routinely asked about cough when entering the facility. That starts from OPD. From OPD, you ask the patient, and even on the ward, you're expected to again ask the patient if they're coughing as part of our control measures. Then there's the environmental controls. Patients' waiting areas are outdoors or have good cross ventilation. This may not be applicable in the ward, but normally there's also a question asking, are the windows open and doors open following that one? So we try to account for all the areas. And there's the question on the personal protective equipment. Surgical masks are available and worn by coughing patients. Surgical masks are always available in the hospital. This time even N95 are available. So we expect to find a yes there. If no, we ask again when they'll be made available. And then the other approaches, these are the healthcare worker-centered approaches. We have the annual healthcare worker screening. And the objectives, of course, are to detect TB disease early in infected healthcare workers and put them on appropriate treatment. Encourage healthcare workers to have at least one HIV test annually. Maintain a database on healthcare worker screening and the prevalence of TB among healthcare workers. And the investigations we do normally are expert. We do an X-ray, FBCSR, RPR. We also test for hepatitis. HIV is optional. And what we found actually, TB is not as common as hepatitis. So that's something the hospital is looking into currently. The other activities, the TB infection control trainings. The idea is to train healthcare workers, but we also invite healthcare worker assistants. This includes cleaners, porters. We have cadre across the board. We have physicians, and during the workshop, we just mix them so that they share ideas. And the idea is to familiarize with the participants to the risk assessment tool and the TB infection control plan, which we have for the hospital. But they also get to go through the process of making a TB infection control plan during the workshop. The other objectives are to build capacity among healthcare workers on how to protect themselves and patients, and also to instill a sense of responsibility concerning TB IC. Like we have a saying where we say everyone is a cough monitor. So like you have the cleaner working there. He sees the patient coughing immediately, he will triage that patient. He doesn't have to go to the nurse. So those are some of the practices we encourage. Then we have the fit testing training. This is for nurses and physicians. It's normally done quarterly. Nowadays it's less because we've trained a lot of people and they're training each other in the wards. But of course the idea is to educate them on how to properly use an N95. And like in my setting, which is resource limited, these disposable masks, someone has to use them for maybe 2 weeks. So they have to know how to store them so that they're not damaged easily. And then of course, teach them how to fit test others on their wards. And then here I just have other related programs. We do sputum collection trainings because most of our patients, when they come to the hospital, like especially very poor patients, you do the spot collection, you give them the other bottle to bring, they won't come back because transport, they may come back 3 weeks later. So we train our staff so that as much as possible, the spot collection will be a good sample so that if the result is positive, we'll call them to come back. The other trainings are programmatic management of drug-resistant TB training. We even invite other hospitals to these trainings. The 3 I's, management of TB for healthcare workers training, and we also have meetings and trainings with other local clinics in Lusaka district because we have to form linkages because all the patients we refer from the referral centers go to these clinics. So thank you so much. Any questions?
Don't go anywhere, Jojo, stay there. Thank you very much for your presentation. And I know Jojo is also an ICN leading light for the ICN TB project, so he does quite a bit. I know personally that he does quite a bit of work in infection control in other areas and improving care for patients with drug-resistant TB and TB. He's very humble. I have a few questions for Jojo, but I wanted to open it up to the floor. Yes, please. Questions?
Thank you, Jojo, for your beautiful talk. I experienced in Tanzania that many nurses wouldn't like to work on the MDR TB ward because they were really afraid to get infected. And I'm working in a Dutch TB clinic, and we have those special masks and all the facilities, but that's a big difference. And the second question was, you test your healthcare workers for active TB. Do you test them also for latent TB, and do you provide latent TB treatment for them as well?
Okay. Yeah, so I'll start with your second question. Yeah, we test them for active TB. We do not test for latent TB. Currently, I know that at the ministry there are still discussions about that because some African countries have adopted isoniazid preventive therapy for healthcare workers. So I think there are still discussions about that. And your other question was about nurses working in. That challenge is there. Yeah. But like with a new facility, the one I was showing you, everything is there. So actually, nurses were actually fighting to work from there. But before then, they didn't want to touch. Yeah. That's how I can answer that.
Thank you.
Any other questions for Jojo? I have a question, Jojo, if no one else does. So in my own area of research and passion is getting healthcare workers to go and get screened for TB. So you're offering them screening for TB. How many of them will actually come to be screened, and do you have any tricks or how to get them to, or things that you do to get them to come?
Okay. Yeah, that has been a very big challenge. Healthcare workers don't like being screened. Like in 2016, in fact, we only had about less than 15%. By 2017, it improved to 25%. But this year, the ministry has taken it up. Yeah, so they want all the hospitals to follow the model we've been using. They were supposed to start in July, but I hear they'll be starting in January. Hopefully, there will be an improvement.
So it's voluntary, it's not mandatory?
No, it's not mandatory. But, you know, but what I've found, like, especially with nurses, when you go to a ward, because you talk, first we start with the matron, and then you talk to the in-charges. But in a ward where you have an in-charge, who comes first? Then all our nurses will follow. But if the in-charge shuns the tests, then you find that no nurses will come.
Oh, okay. So we need to engage the leadership to participate.
Yes.
Okay. Thank you. Any other questions?
Yes, please.
Thank you, Jojo, for a very comprehensive talk, particularly the use of drama groups in raising infection control awareness within the community. But my question is relating back to yours, Carrie, about healthcare workers and of those that possibly may end up with active TB. What we have found in the UK is that they don't present early enough. And you think because of their healthcare knowledge that they would do that. But again, that word stigma crops up and prevents them coming forward. Do you find the same observation?
Yes. In fact, there's a lot of stigma between healthcare workers. So much so, like, for example, one of the World Health Organization recommendations is that, for example, if a nurse is HIV positive, she shouldn't be working in an area with TB. So much so that we've come up with a system where nurses are scared to say when they have HIV. So what happens is that they talk to the matron. So now it's like every 6 months people are shuffled. So during that reshuffle, people are moved around so that no one will be able to point a finger. So such initiatives are actually helping, but there's a lot of stigma between healthcare workers.
Okay. Thank you very much.
Okay. Thank you very much, Jojo. And so now I would like to invite Niesje to come and talk, and again to thank you, Niesje, for organizing this special presentation and pushing forward and making this special session on nurses happen.
Good afternoon, and thank you for my co-organizers that they gave me the opportunity to tell you something about the way we organize nursing care in the Netherlands. I have no conflict of interest. I'm working for KNTV, but I have no conflict of interest anymore. The Netherlands is a small country with approximately 70 million inhabitants. The number of TB patients is decreasing till 787 in 2017. We are a low incidence country with less than 5 cases per 100,000 in 2017. Nearly 2/4 of our patients is foreign-born. As you understand, TB is in the Netherlands an import disease, mainly an import disease. In the Netherlands, TB is one of the diseases who needs to be mandatory notified to the regional public health services. They are registering all patients with TB in the Dutch TB register. There are 25 public health services in the Netherlands which have a TB department, and you see them located on the screen. The persons are the nurses working in TB control. Almost 80% of the TB patients in the Netherlands are diagnosed in general hospitals, mostly by pulmonologists. The other 20% is diagnosed at a public health service, mainly by active screening of migrants or contact investigation. For all patients, as well for those diagnosed in hospital as for the patient diagnosed at the public health services, treatment support by the TB nurses from the public health service is available and offered. Nearly all patients, as you can see on the screen, are getting some kind of support from a TB nurse. There are 2 important principles in TB treatment in the Netherlands which influence the way of nursing support. Patients are mainly treated ambulatory, and we try to give individualized care to the patients. So not one size fits all, but we try to tailor the care to this person with TB. Very important for the Dutch situation is that treatment for TB is in general ambulatory. When persons are diagnosed with TB, only 25 to 30% is staying in hospital for more than 1 week. And even when patients are smear positive, the majority is treated fully ambulatory. As you can see on the screen, less than half of them is hospitalized for more than 1 week. So half of the patients is isolated at home. This has, of course, consequences for the care to these patients and the household context, of course. When smear-positive TB is notified to the public health services, the TB nurse will contact the patient in general the same day or the day after to give advice about infection control measures. The TB nurse will give health education to the patient and his family to inform them about the disease, the way it is spread, and especially it is not spread, cough hygiene, the use of respirators, etc. It's very important that the patient feels comfortable with the situation and that more practical issues are solved, so that it is feasible for the patient to be isolated in the home situation. If someone is living alone, it is important to check if he or she has friends or family to buy food, take his medication from the pharmacist, etc. The TB nurse will give attention to all this aspect in the first visit of a patient with smear-positive TB. Nursing care for patients with TB provided by the public health services has 2 elements. On the one hand, individual care, which can be divided in health education, adherence support, psychological support, and socio-economic support. According to the guidelines, the support of the TB nurse starts within 3 to 4 days after notification. I already told you that we try to give care tailored to the individual patient. Therefore, the support starts with collecting information about the patient, because you need to know who is this person, as also Carmen told you about. A standardized questionnaire is developed by the Dutch Nursing Association in cooperation with KNCV to structure this collection of information. As you already know, a lot of our TB patients is foreign-born, and we see, especially for the asylum seekers, that they are moving very much across the country. So it's important that information and care can be taken over by another public health service or TB nurse. A lot of information is gathered. General information about the patient as well as about TB, symptoms, patient and doctor's delay, diagnosis, treatment regime, etc. Other health issues like comorbidities, but also what people think about their disease and how they think they can deal with treatment adherence. A separate part of the questionnaire is about social information. It is more focused on the way people are living. Are they belonging to a risk group? Are they homeless, or are they addicted to drugs or alcohol? Are they living alone? Are they having children? Do they have a job? Do they go to school? Do they go to church? Do they do sports? All those kind of things are gathered for two purposes. On the one hand, to make a decision together with the patient if treatment adherence is an issue and if the patient needs help in this. But the information about all the social aspects is also gathered in case of contact investigation. I will tell you more in depth about this when I tell you about the task according to public health. The nursing care is divided in 4 pillars. As you all know, health education is very important. To motivate people to take medication for 6 months, they need to know what is TB. What does it mean to me? And why is this medication necessary? But also for infection control and contact investigation, knowledge about the disease is very important to increase the coverage of your contact investigation and to overcome stigma. As we have a lot of foreign patients, often interpreters are used in giving verbal health education. The TB nurse has the opportunity to make use of interpreters for a lot of different languages which are available by phone. Information about all aspects of TB is also given by leaflets or by websites, also in different languages. The most important aim for the nursing support is enable patients to complete their treatment. So the support is very much focused on this from the beginning. As I told you in the patient history, information is collected to decide together with the patients is help necessary to adhere to treatment. Some nurses in the room you recognize on the screens. This can be DOT. This is used for approximately 25% of the TB patients yearly. Not for all these patients, DOT is given during their whole treatment. Sometimes it's replaced by pill dosages during treatment. These are boxes which are filled weekly, so it gives some structure, because it's clear if you already have taken the medication that day. But a lot of patients in the Netherlands also make use of self-administered treatment, sometimes by help from the alarm in their mobile phone or other reminders. In the decision of how people can best be supported in their treatment adherence, we take into account the patient's living conditions. If he or she is already a daily client at a homeless center, we try to involve the healthcare workers there to act as a DOT assistant. To illustrate the psychological support, I will read a fragment of the diary of a TB patient. You see her photo on the screen. On a Tuesday morning, I woke up and I coughed a lot of blood. What's wrong with me? I went to my GP and he immediately sent me to the emergency medical care. Not much later, I'm lying in a hospital bed with an unreal, almost giggly feeling. I'm hospitalized, in quarantine on the lung section. The entering doctors are wearing face masks. I cannot imagine I was free walking around just a few minutes ago. The lab results confirm the suspicion of the doctors. I have open pulmonary TB. The next morning I wake up and look at myself in the mirror. There I am with a sick lung. I cannot see it. Yesterday and the day before yesterday it was already there. That makes me uncertain. I feel let down by my own body. The Netherlands is a low incidence country. We have TB in control, as we say. But for the individual patient, it is still a nightmare. People are not familiar with TB. It's a rare disease, so they are raising a lot of questions and sorrows when people are diagnosed with TB and they are unable to speak easily about this. The TB nurse will take this into account during her support, as all these uncertain feelings can influence treatment adherence. The last but surely not less important part is the question if people are able to adhere to treatment. Are there financial problems, or is someone undocumented and fears for eviction? The TB nurse will also take this into account. For undocumented migrants, we have an arrangement in which postponement of evictions and a reimbursement for housing, living, and health insurance is included. The TB nurse can initiate this arrangement so the patient can apply for. More about this arrangement we can also tell you during a poster session about this subject. We have a poster session tomorrow on this, and a presentation later on in this conference. In the Netherlands, we also have the fund Special Needs, managed by KNCV. With this fund, we can help TB patients to overcome some financial barriers. The boy on the screen got a bike to enable him to come to daily DOT at the public health services. After completing his treatment, the bike was given to him as an incentive. Beside the individual care, there is also a public health aspect in nursing support. The most important in this is contact investigation. In the Netherlands, we use the stone in the pond principle for contact investigation. First, we start with the close contacts, and if transmission has shown, we scale up to more occasional contacts, like job, school, sports, etc. The inventarization of contacts and the coordination of the contact investigation is part of the job of the TB nurse. As I told you before, also for contact investigation, health education is very important. There is not much knowledge about TB among general public. And when a friend or a family member or a colleague is diagnosed with TB, there are sometimes, mostly, a lot of questions. The public health service is also available for these kind of questions. Also, when patients are diagnosed at hospital and are lying at hospital after diagnosis, support by the TB nurse is started soon after diagnosis. TB nurses are visiting patients in hospital to prepare them on release from hospital, but also to discuss contact investigation if necessary, of course. We do have challenges. Our most important challenge in TB control in the Netherlands is to maintain knowledge and awareness on a high level despite the decline in the number of TB patients. And although nursing support is given to TB patients for decades, there is a lack of scientific evidence published and nurses are trained on the job. With a decline of patients, this is going to be a problem to deal with. Therefore, we started a research project improving patient support interventions in 2016. KNCV started this in close collaboration with TB nurses representing all regions, the Dutch TB Nursing Association and patients. And we already completed a systematic review and a European survey on patient support. These two studies are already published, and in the presentation I add a link, so when you got it, you can easily see the articles published about this. In the review as well as in the survey, we show that a variety of patient support interventions is implemented in low-incidence countries. We identified some potential best practices, but we saw also that only a few interventions were evaluated quantitatively. To complete the research project, we are now doing a study describing the current situation in the Netherlands. In 2016, we also started a basic course for nursing TB care, including e-course. TB support by nurses is common in the Netherlands and is integrated in some guidelines, as for contact investigation. But there is no overall guideline for nursing support for TB patients. There is also no structural use of new technologies, and there are some experiments with the use of this, video observed therapy by using Skype or WhatsApp, but it's not structurally implemented as one of the tools. Our plans for the future are to finalize the research project so we can provide the evidence for the development of a guideline, which we hope to start with in 2019. To improve the use of digital health and maybe to include this as a structural tool in nursing support, KNCV is working on a digital health plan together with all partners involved in TB control in the Netherlands. Because we think to have a stable nursing support system for the future, also when there is hopefully a further decline of TB patients, these steps are necessary. I thank you all for your attention.
Thank you very much, Niesje, for your clear explanation of our situation here in Holland. Due to the decreasing incidence, we have the challenge to keep up our profession and the possibilities, of course, also for giving ambulatory care. And I am positive that the new technologies will help us with this. Are there questions from the floor? No, it was a very clear explanation.
Carrie has a question.
Luckily.
Thank you, Niesje. Beautiful presentation. I'm interested in your course that you have for training Dutch nurses, your basic training course. I wonder if you could describe for us the length of the course, the content of the course, and evaluation of nursing participants in the course.
Yes, I can. We had a course of, there are several participants of the course in the room, so they can tell you all about this. And we had a 7-day course, yes, of face-to-face contacts. And it was about general TB, diagnosis, the disease. It was given by a TB doctor, about medication, all medical things. And then we had a nursing day about nursing care, and that was prepared by an e-course. We made an e-course about daily care to TB patients. Sorry, it is in Dutch. So, so we made some case studies, and you follow a nurse during these case studies in this e-course, and that was to prepare the face-to-face day. Then we had a day about communication, how to communicate via trainers with role plays, etc. It was always difficult to do, and not everyone likes role plays, but at the end it is good to do it that way, I think. Then we had 2 days for contact and investigation, and and I think it was great. We tried to do it for the first time, and that we all the nurses who participate in the course made made something they can use in daily practice. And they also presented it during the yearly training days for the TB nurses, so it's also a continuity of knowledge sharing. But the difficulty is always is when you have a small number of nurses newly, that how efficient you can give courses. And that's also why KNCV took the opportunity, because for commercial institutes, it's not you can't give courses to 3 or 4 people. So that's the way we have to see. Last year we had 16 new nurses because of retirement of a lot of TB nurses. And but we now see what we have this year, if we can continue this year also. But that's also a challenge to deal with.
Thank you very much, Niesje. We are now coming to the end of our presentations, and I would like to give the floor to Linette Mc-Elroy, chair of the NAPS. She will summarize this meeting for us and take the opportunity to look forward to the future with us. Linette?
Thank you very much. How are we doing for time with the agenda? We have the photographer coming at 6:45.
13 minutes.
We're all
Coming
right?
at 6:45?
I'll speak a little quicker than I planned. So thank you for
We'll
the
let him
introduction.
wait.
Okay, we'll let him wait. As was said, my name is Linette Mc-Elroy. I am the chair of the NAPS subsection for the union, as well as many other things. Carmen's talk about how we describe ourselves really resonated with me, and I was thinking, how do I describe myself? And most often I start with, I'm a nurse. Or I might say I'm a mother. I guess it depends on who I'm talking to, or a grandmother, depending who I'm trying to fit in with. But I am the chair of the NAPS. I'm also the lead for the TB education and training work group of the union. But I am a TB nurse by training and have been doing that work for about 25 years. About halfway through that, I started doing special projects related to TB education and training, and traveling throughout my country of Canada to help TB programs put together trainings and resources. And most recently, I've been starting to work in policy and politics, which has been a really interesting transition for me as a nurse. Certainly not something that I was trained to do, but I think none of us were either trained to use keyboards or digital technology either. So we're always learning. So I found this meme, as they're called, and I thought it was really suiting for this group, that in terms of resources, we are our greatest resources to each other and to ourselves, I think. And so I just wanted to start off on that foot. I'll also mention that I have no conflicts of interest for this talk, so I'll include that in the slides that Niesje shares with you as they go out. So this is where I am from, and some of you might recognize this map as the WHO TB incidence map. And I like to use this map to describe where I'm from and to put context into the work I do, because on the WHO map, when you look at Canada, here, it's white, which means that we are a low incidence TB country. But I think those of us that work in TB know that sometimes these maps are misleading, and they can be misleading. And certainly in terms of the population that I'm working with currently, it's a very misleading picture. So I'm just going to advance to our next slide, which describes some of the work that I've been invited to be involved with. And that is working with the Canadian Indigenous population known as Inuit. So in some jurisdictions, they may be referred to as Eskimo people, Northern Living people, Innu people. So in Canada, we describe this population as Inuit, and Inuit describe themselves that way as well. So on this map, I just want to point out to you, this is a graphic that we used for World TB Day this year. We produced it in combination with the Canadian government. And just to show you, Inuit in Canada live primarily within the 4 Inuit regions, which are the Canadian Arctic. Of course, Inuit people also live in the city, or maybe living outside of the Inuit homeland or Inuit Nunangat to seek medical care for many issues that cannot be cared for in the far north. But among the 4 Inuit regions of Canada, we have quite a variability in the TB rates. In the Inuvialuit settlement region, the rate is 1.5 per 100,000, which is much more in keeping with what you would see in a Canadian-born non-Indigenous population. But when we look at some of the other Inuit regions, we're seeing rates of 180 per 100,000, 234, and 248 per 100,000. So very high rates of TB, and again, not something that you would have guessed from looking at that WHO map that said Canada was a low incidence country. So this is my current context of work. So what are nurses, and how do we see ourselves? And our former conference chair, Stacey Stender, would like to produce these wordles and use them in her talks. And I thought this was a nice one around nursing, because I looked at some of the words on here and they resonated to me. I've included, as well as an educator, I just can't help but throw some education in here and give you some resources. So if you'd like to create some wordles online, there's several different tools, but this is one, word clouds. You can do them for free. You just pop in all the words you'd like to describe something, and it pops out various different iterations of that for you to include in your presentations and whatnot. So what is nursing, and who are nurses, and what do we do, and how do we relate to each other? And that's sort of what I'll be talking about today in this presentation. I think nurses are awesome. Not just because I'm one, but I think I've always been inspired by nurses and decided to become a nurse because of experiences I had as a young child. My mom was a laboratory technologist, and so I spent a lot of time at the hospital going to retrieve my mother from work because she was often late leaving, and so sort of met through her friends and her network and learned about the job of nursing, the role of nursing. These are some particular TB nurses that are near and dear to my heart. This is from the North American region of the TB, of the Union conference a couple of years ago, where we overtook the conference with a flash mob. And if you can just imagine a scientific conference, very scientific, much like this one, with one large room of scientists and researchers primarily sitting watching presentations, who by the end of this flash mob were up dancing and clapping. So we'd never seen it before. I'm not sure it's been done again since, but these were TB nurses that came out, and some of us actually had never sung in public before, so had the courage to sing in public. And one of our Aboriginal nurses actually brought her drum and drummed along to the song. So I think TB nurses are awesome. If you can not read the message on the sign, it says to spread TB knowledge and not TB disease. So as a nurse, I think that's one of our primary roles, as well as being all those other things, including advocates for TB. But how do we connect outside of our programs? We've heard about some awesome programs and initiatives that people are doing in their own programs, their own countries, their own regions. But how do we learn from that? And how do we really use each other as resources in this digital age, which I consider myself an elder now, I'm trying to keep up with, and sometimes failing, sometimes succeeding, that sort of thing. How do we really take advantage of all the tools and ways of staying connected that we have available to us in this digital age? And I don't know the answer. And so as I'm looking across the room here, it's really pleasing to me as someone who's been in TB control for so many years, almost 3 decades. It scares me to be able to say that. When I look out, I see such diversity in ages. And I welcome all of you that are newer to TB. It's wonderful to have you here. But I also welcome you to teach us. As much as we're going to teach you things and share our knowledge as elders, we need to be learning from you as well, especially about this stuff. Carmen, who spoke earlier, is actually a friend of mine. I've known Carmen for about 20 years now, and we often banter back and forth about this challenge of keeping up with the younger nurses and how much we learn from them. So anyway, moving on. In terms of networks, we've heard from Carrie. It's wonderful to have you here, Carrie, from ICN. I've put this slide up as an example of how nurses stay connected to each other. And for those of you who are less familiar with ICN, the International Council of Nurses, there's a description here lifted from their webpage, just a very small portion of how ICN describes itself. And of course, their logo, their emblem, is that what you call it? Their logo, which is lovely, and I don't know if you have any pins left, but
I don't have any pins left, but I'm happy to give this to someone because I can always get.
She has a source back at home, I guess you think, yeah. So this is one of the networks available to nurses to stay connected and to learn and share and be resources to each other. Another, and of course this resource that they've produced, the I Am a TB Nurse and I Love My Job. Thanks, Carrie's brought a few copies of this for us, and they're down at the nursing booth. So if you'd like to take this home to your program, they're sitting there. Please help yourself to that. So thanks for that, Carrie. It's a wonderful thing. People love to see themselves. And again, it's a teachable moment. When I'm doing training and education, especially if it's multiple days, I'll often sneak around and take pictures of each other. And then the last session of the day, I'll put them together into a little, I'm not technically savvy enough to make a video, but I'll do a quick PowerPoint to say who was here and what we did. And people are just engrossed by it. They love it. But these are really great pictures. And if you haven't been to the TB NAPS booth, down in the exhibition hall, please come by. There's some beautiful photographs that were submitted recently in order actually to put in that booth. So pop on by and see. You might recognize yourselves or people that you know that are there. So thanks, Carrie, again, for bringing this resource. This, again, is something you can do in your own workplaces and something that I've done and recommended to others several times for World TB Day as a very simple grassroots way of creating teamwork and that feeling of a bonding among your TB nurses.
I gave one to the new WHO.
Oh, yes.
When the new WHO Global TB Program Director took office, I made a big poster for her. It was around World TB Day of the one that Linette just showed, so that she could hang it in her office as an office warming gift, and I've been told it's still
So
hanging there.
subtle,
So
so
she
subtle.
has to see us every day.
It's a lovely reminder of the support network available to her and to the work she does.
That's great.
Another network that you may or may not be familiar with, because this is, I've found in the years I've been working with this group, tends to be sort of North American or American-centric. So over here on a different continent, others may not be aware, so I want to be sure to tell you about it, is the TB Education and Training Network, or TB-ETN for short. It is the initial branch of this networking that the Center for Disease Control in Atlanta set up. They have another branch as well now, the TB Program Evaluation Network, or TB PEN. So some of you in the room might be both educators and evaluators and wear two hats. Many in the United States, many of the people that have these responsibilities wear both hats too. This network is open to anybody. It's a global network. It's free membership. They have an in-person conference where both networks meet at the same time, so they can sort of cross-pollinate every 2 years. It's held in Atlanta. That's sort of the downside to that, so you have to get there. But the conference is free as well. It's usually 2.5 days long, and it's fantastic. It's completely skill building. And I just got an email actually that their presentations are available online. So they do make the conference materials available online for people that can't attend the conference. So if you're interested in either one of these topics, there's another network that you can get involved in to grow your own personal networks and your resource list and your skills building opportunities. Are there any TB-ETN or TB PEN members here? No. We also have a really nice pin, which I'm wearing. Not saying that it's nicer than yours, Carrie, but it's nice to have a pin. And sort of on that note, I wanted to build on what was said earlier about the green T-shirts and that visibility and all the benefits of that. So that green T-shirt was a brainstorm of Carrie's, and one that she made come to fruition for Cape Town. For Liverpool. So, but she brought the T-shirts from Durban, I guess it was, all the way up to Liverpool to be handed out. So you can imagine Carrie on the train, as well as her luggage, with these bags and bags of T-shirts, and then we handed them out. But to look around the room, you immediately knew who the nurses were. We were very visible. And so with this conference, we were trying to come up with a similar idea. How do we manage to make ourselves visible to each other? Because on the card, it doesn't actually say nurse, it says delegate, or depending what kind of card you are. And I think these opportunities, when we get together, when we don't have that visibility or that way of identifying each other, it's a missed opportunity to create networks, to find out what other people are working on, to find out what you have in common, what challenges other people have already overcome that you're just starting on. And if not for this event here, I wonder how we might have done that. Certainly we do have the NAPS group, and we had our NAPS general meeting this morning, and several of you in the room were there today, and even though it was quite early, 7:45, thank you for coming. And that often happens. It seems like we get the 7:45 slot. So we try to make these opportunities at the union conferences for nurses to gather, and we are more or less successful depending on things like the scheduling. Or if there's other, not just the timing, but if there's other sessions happening at the same time, then people have to choose. So this idea of having a gathering that's just for nurses, that for hopefully not competing with too many other things for the time with, was one of the reasons that when Niesje reached out to us, we were just so excited to say, yes, like what can we do to help support that? And I just want to take a moment to congratulate Niesje, who's busy. She's still working. As well as a couple other people in the room, Oda, who are in the room, who are on many Skype calls that we've held over the last few months. So yes, this networking idea, I hope that it takes off and we can repeat it in future years. So in the NAP subsection, as I said earlier, I am the chair of that subsection. Following close behind me in my footsteps and who will take over for me once my term is done is Amanda Christensen, who I'd like to introduce here. Amanda is the program secretary for NAPS. just delightful. I mean, she's Australian. I try not to hold that against her, but most of the time, she's lovely to work with. And just to give a bit of sort of brief overview of the two roles in the NAPS group, in case any of you are interested in perhaps becoming more involved in NAPS, we begin as the program secretary, and part of Amanda's role is to help set the program for the conference, which, when you think and step back, the union was primarily a scientific origin. It's physicians and scientists. And then nurses became more and more involved. We're now to the point where we have a nurse on the committee that decides what gets into the conference and how the program gets laid out. So I think that's tremendous and something we need to be really proud of. So I think the program this year is fantastic. It's great to see so much nursing stuff in there, or things of interest to nurses, or translational science, knowledge translation that's accessible to nurses in different ways. And now we have Amanda to thank for that. So thank you again, Amanda, for that hard work. It is hard work. I've done it. Carrie's done it. Others have done it in the room. Yeah. So the other Carrie. Yeah. So NAPS. So this is the Nursing and Allied Professionals subsection of the TB section, or of the union, of the scientific section of the union. So it's quite a structure. And we were having conversation earlier today at our annual meeting about the allied professionals. Who are they? What does that mean? And how do we engage them and reach out to them and involve them? And after the session this morning, I had one of the women in the room was a social worker. She came up to me and she said, I think I might be one of those allied professionals. I'm not sure, is there a social worker section? And I said, there isn't, but you're welcome to be in our group. So we think of ourselves as primarily nursing, because that's easy to identify in the title, but we have health educators, we have social workers, we have others.
Helen is one of
Helen?
our allied professionals. And behind you.
So rest assured, for the allied professionals, we will be working in the coming year to try and identify who you are so that we can get you more involved in our work and more reflected in the work that we do. I wanted to just really briefly, because I know it's the end of the day and I'm standing between you and your dinner, and that's the worst place to be in, to give you sort of a sense of who our membership is made up of. We have a large component from North America, Europe, Africa, and Asia Pacific, and then smaller components from within the other regions. Over the next year, we're going to be trying to grow and sort of even out the representation. We're seeing a decline in our membership that's happening throughout all sections of the union, not just NAPS, and that's something that I'm hoping this meeting can put an end to. We'd like to see the numbers going back up the other way. Part of that work is, I think, for Amanda and I and others that are involved, is to define what the point of being a member of the union is as a nurse. What does it have to offer you, and what do you have to offer it? So we'll be working on that in the coming year. Any of you in the audience, I won't make you put up your hand because this isn't about public shaming, who aren't members of the union, who aren't NAPS members, who would like to become, you're very welcome. We encourage you to register, and we'll hopefully be connecting with you in the coming months about that. So just a couple very brief slides before I finish. I wanted to point out that W.B. Yeats, a famous Irishman, there are no strangers here, only friends you haven't met yet. And I think that's really true of this group, and for the networking activity that follows this session, hoping to really build on that. But as you leave the session this evening and you go back to the conference tomorrow and you're looking around, if you could keep this in mind, because in my time in TB and the other conferences I've attended outside of TB people are the best people. We truly are. We are the nicest people. We do the best, most important work. But in all honesty, I've not been in an organization where I've felt, or within a group, a cadre, a cohort, where I felt like I could walk up to literally anybody and speak to them. And that's really how it is in TB, and that's not how it is in other places. So this conference is your chance to really take advantage of that. Don't be afraid to walk up to that person that you think, oh my gosh, I've seen that picture, famous in the TB world. Everybody here wants to meet you, and it encourages that. So getting back to the networking, whenever I go running, I meet two people, like meet new people like paramedics. So just try to put a bit of humor in here, because I think that many of us are perhaps I could say socially awkward, nervous, anxious about how to meet new people. So just to let you know that it's not just you. And to leave you with one quick story about how a simple hello could lead to a million things. When I first began working up in the far Arctic, I'd moved up to the far Arctic, and I lived there for 4 months. And while I was there, there was a federal election going on. I don't know if any of you know anything about our Prime Minister in Canada, Justin Trudeau. Anybody ever heard of him? Right. I was completely disengaged with the election because I felt that the competitor was going to win, and that was just going to be bad for people. And so Justin Trudeau came to the small town in the very north of Canada where I was living as part of his promotional tour. It happened to be Thanksgiving weekend, and a bunch of us were actually getting together to have turkey, and we were going to have to leave our turkey dinner to go down to meet him at the high school where he was doing his talk. And the other thing that was going on, it was radio bingo was happening, and we'd all purchased our bingo cards. And radio bingo is exactly what it sounds. You sit at home with your bingo card and you listen on the radio as the numbers, and then if you get it, you phone in, and then wait and people win. So we were in between games of the cards, and someone said, Justin Trudeau, we got to get down there and meet him. I want to meet him. So we left our bingo cards and our turkey dinner. We raced literally just down the hill to the high school. I was only there to take a picture of someone else who was just so keen to meet him. I was, as I say, completely disengaged. So I took the picture. He was very gracious to my friend, and they had a little chat. And then I turned to leave, and he reached out to me and he said, "Hello. Thank you for coming." And I was standing there. I was completely unprepared to speak to him. And all I could come up with was, "Good luck." And as soon as I turned to walk away, I thought, tuberculosis, housing, food security. I could have said anything at that moment. And I just was not prepared. So just to leave you with the thought that you never know who you're going to meet. So have your message ready. Because especially in a forum like this, you never know who you're going to end up in that elevator with, the 5-minute elevator speech. So
I just did it with Eric
Grisby.
right before this meeting.
See?
Amanda is my witness.
But did you get a picture?
I didn't get a picture, but I did say that without nurses, we're never going to end TB, and please use your platform to talk about the role of nurses in TB. And he gave me his private number and email address for me to follow up with him.
Can we share with him? No. So,
if he doesn't answer
yeah.
my first email, then I will public shame.
Okay, then you'll share it with us. So that's a really great, I think, note to end on, is that think about that message. Think about what it should be about, who your audience is with. Sometimes it's about TB. Sometimes it's about nursing in general, and finding our power and finding our voice and being connected and feeling as though you're part of a community, because you are, whether or not you realize it. As I said, TB nurses are like the best nurses, and you're among that community. And the allied professionals, again, you're among a really vibrant and rich and welcoming and supportive community. So take advantage of that and try to build your network, and use this evening and this conference as an opportunity to do that. Join the union, join NAPS, become involved in whatever small way you have time for. Every little bit helps, and is a way for you to give back, but also to build your network. These conversation starters are for the socially awkward among us. You can take them away, and it's something that we're actually going to be working on in the next session of the meeting, actively at our tables as we go through our dinner. So I'll take them down for now, but get us out of here. And just a plug for the frames. We have 2 of them here this evening. And please do take your photos with them. One of the things that we're trying to do over the next couple of years is actually build a library of photographs of nurses and allied professionals, so that we can use them with the union activities and with our NAPS activities. So they're for you, but they're for us as well. So if you want to tweet them with the hashtag that's on the bottom, that would be really helpful. So thank you for your time. Enjoy the rest of the evening. Enjoy the rest of the conference. And thank you again to KNCB for bringing us all together here, and the Dutch Nurses Association. I think just one more round of applause for those of you who are not staying. over to you.
And I forgot, Niesje, before we started back up, to say what you told me to say. So she did tell you that she's going to share the slides. She'll send out an email next week with all of the slides from the presentations. But what I forgot to tell you was that we've been recording back there the whole time. So I hope I look good on the camera. So she'll make a link to the video in the email that she sends to us as well, so we can share that with colleagues who weren't able to join us here.